Okay, I think we should get started. I'm Lori from HIS Talk. Welcome and thank you for joining us for today's webinar entitled Keeping It Clean, How Data Profiling Leads to Trusted Data. It's brought to you by Encore, a Quintiles company. Attendee phone lines have been muted to prevent background noise. You can use GoToWebinar's questions box in the console to submit your questions to our presenters at any time. The presenters will answer questions during Q&A at the end. Today's webinar is being recorded, so you'll receive a follow-up email with a link to the recording as well as a PDF version of the PowerPoint presentation. We have 3 speakers today. First up is Randy Thomas. Randy's the Associate Partner responsible for Performance Analytics at Encore, a Quintiles company. Joining Randy will be Lori Yaskinish, who is the Administrator of Clinical Informatics at Lehigh Valley Health Network, and Joy Alice, a Senior Consultant at Encore, a Quintiles company. With that, I'll turn it over to you, Randy.
Thank you so much, Lori, for that introduction, and thanks everyone for joining us today, talking about a topic near and dear to my heart, which is how you ensure that your data is as you expect it. This is the 3rd in our series of webinars. It's all about the data. And today we're going to cover, why is data profiling a discipline that healthcare organizations need today, get into a definition of what data profiling is, talk about the value your organization is going to realize from profiling your data, where you should apply this discipline, and how you get started. So I'm just going to start things off here, setting a little bit of a context. We can go to the next slide. Context of why focus on the cleanliness of your data is so important. And it's a theme for those of you who are joining us for the 3rd time and talking about It's All About the Data. It's a theme that we've consistently been reinforcing, which is in this world that we're living in, where we're evolving from a fee-for-service reimbursement approach to a very value-based approach, where there's this focus on the outcomes of care delivered and the health of a population of patients that you're responsible for. In order to ensure not only that quality of care and the outcomes you're expecting, you need to understand what your performance is, and that performance is going to be very closely tied to reimbursement. This shift, of course, is unevenly distributed across the country right now. Some parts of the country are experiencing far more of their commercial contracts that have shifted to a fee-for-value approach, but it is a trend, of course, that that is gaining momentum. So this focus on the data that underlies the metrics that support how you measure your performance is essential. We'll go to the next slide. And I think the bottom, unfortunately, the very bottom of your slide might be cut off. This is a diagram that Dr. Tanya Honksemeyer, who is the CMIO at Lehigh Health in Massachusetts, this is a diagram she drew on a whiteboard one day to describe the sort of her concern about all of the various programs and commercial contracts that used metrics to report out performance for those programs, and that reimbursement was increasingly getting tied to. And it is an alphabet soup of programs and registries and contracts, and these overlapping circles just represent the plethora of metrics that organizations need to be concerned about. And not all of them may apply to all organizations, and there may be some that apply to yours that aren't represented here. But that understanding that it's the data that you're collecting in your source systems, particularly your EHR, that feeds into the metrics that are then being used to report out against whether it's PQRS or Medicare Shared Savings or meaningful use or a commercial contract with your Blues, whatever it might be. And this sort of alphabet soup, if you will, of all of these different programs is really growing, not declining, and the metrics overlap, and you really need to understand the data that's feeding these metrics so that you're assured that that it's consistent and accurate, and therefore your performance reporting is accurate as well. We can go to the next slide. So this is, again, for those of you who have joined us before, a repeat of this concept that your source systems are not only supporting the workflow and the day-to-day activities, clinical activities, operational activities, administrative activities, not only supporting those activities, they're also collecting data, these individual data elements. And this data, your organization's repurposing in a variety of different activities, different analytic applications and reporting tools to support the various initiatives that your organization's focused on from a performance perspective, whether that's Medicare shared savings or other kinds of performance-based initiatives in your organization. And as as that data is making that journey from its point of capture up through a collection of data elements to support these applications and so forth, it's critical that you know what that data is at the point of capture so that you can rely on what what that data is going to be calculating. Too often you hear in an organization when folks are first looking at a report that they've been waiting for, using data from EHR, other systems, they'll look at it and go, this report is wrong. Frequently it's not that the report is wrong, it's that the data just isn't as you expected the data to be, and that can frequently be tracked back to how it was captured or how consistently it was captured in those source systems. Let's go to the next slide. So as you think of a continuous cycle of you're implementing and going through your source systems, or you may be going through optimization of those source systems, that's where you're making decisions about how you're supporting workflow, but also how you're capturing particular pieces of data. And that data will be flowing into an analytics environment, different applications, analytic applications, perhaps an enterprise data warehouse that you'll use to aggregate and calculate and report. And that will be supporting your performance improvement effort. Well, you want to be sure that as this cycle is going on, that you are confident in the quality of data that is flowing from your source systems, from the decisions that you've made around system implementation and ongoing optimization, that data is flowing into your analytic environment as expected, so that you can be confident in the reporting and measurement calculations that come out of that. So I'm going to turn things over to Joy now, who's going to kind of get into the nuts and bolts about what data profiling is. Thanks, Joy.
Thanks, Randy. So what is data profiling? From a technical perspective, it's a statistical analysis and assessment of data values in source systems for consistency, uniqueness, logic, and it evaluates the actual content and the structure and the quality of the data by exploring relationships that exist between the value collections, both within an application and across data sets. Data profiling really helps you understand your data both from a technical perspective, but also clarifies the context and the significance of the data. And by knowing what the data looks like and what shape it's in, organizations can make informed decisions about what to do with the data. So there's really 4 components of our focus when we talk about data profiling. The first is really to assess the data integrity. And through this exercise, we gather, the objective facts about the data as it exists in the source system. So this can include, the existence of data or the non-existence of data. Are there null values? Or how often do we have null values in a data set? We also review the type of data, whether it be text or numeric, or any data value ranges, 4 to 10, 4 to 500. any minimum maximum values and patterns of the data. Is it always 3 digits? Does it always have 2 digits after a decimal point? Those kind of things are really the facts about the data. The second is looking at data specifications. And these are really the standards or your business rules or the reference data that tell us what the data should be or how it should look in the system. And this information we use to compare with the data findings from our data integrity component. So measuring data accuracy, the third component, is that process of comparing the data integrity findings against the data specifications. And there's really 2 parts to the accuracy. Is the data valid and is the data right? And validity tells you if the facts of the data meet the data standards. So an example would be, zip codes usually have either 5 numeric characters or 9 numeric characters, depending on, what you're using. And if the data facts say, yeah, I have all 5 or 9 numeric character lengths, then the data technically is valid. However, when you look at the data values themselves, you may find that there could be a large percentage of zip codes that are, represented by all 9s. Then you'd think that data is suspect. So just because the data is the right format doesn't mean that the data is right. The fourth component is consistency and synchronization. And this is really comparing information and determining, which data are equivalent and which may need processes to make the data equivalent. So for an example, we look at different EHRs and the way they capture a patient's gender could be different. So in one system, a gender may be represented by an F for female and an M for male. And another system may actually use the words female and male, and yet another system may actually use a numeric representation like a 1 or a 0. They're equivalent data, but they're captured differently in the source system. So those of you that are on previous webinars will recognize these slides done by the Mayo Clinic. But it's really a great job illustrating how equivalent information and terminology, like the main floor button of an elevator, can exist in a way that's non-standard and potentially confusing. And data profiling helps us understand those differences. So how do you get started? So we organize data profiling efforts around people, processes, and technology. The processes, what are the business processes? What's the workflow? What's the policy and procedures that guide the creation of the data? The people, you work with your SMEs, your data SMEs, and the technical SMEs so that you can actually get the data out of the system, which sounds easier than it is sometimes. But you really want to make sure that you're understanding how the data is created and validate those findings are as expected. And then from a technology, how do you evaluate that data? And there are multiple tools that you can use to evaluate the technical aspect of the data. You can use, something as simple as Microsoft Excel. There are free downloads on the web, or there are actually commercial products that are available for purchase as well. So we apply a standard PDSA improvement model for data profiling lifecycle. And the first step is really to prioritize those data elements in your source systems for profiling. You do not want to profile every data element in your system. A lot of the systems will contain transactional data that may or may not provide value. So you really need to prioritize where do you want to profile your data and what do you want to use it for. The next step is really to conduct a quantitative and qualitative analysis of the data. And this is that process we described earlier with those 4 components, comparing those data standards and the rules with the data fact values. You review that data and validate those findings with this means, and we'll get into a little more detail on that. From there, you want to analyze all of that data and all of the information that you've gathered, and you can categorize that information into a high, medium, and low reliability. So with all of that information, your organization will then be able to decide on what to do about the data and have a better idea about the effort that will be involved to make changes or remediate. So let's take a little closer look at the quantitative and qualitative assessment. And this is an example of the types of findings you might see. From a quantitative perspective, it's really those objective findings, whether there be null values or, what's the format of the data. It's really the facts of the data. It could be type, format, the frequency, whether or not it complies with your, drop-down lists, those kind of things. From a qualitative review, this is really about, do the objective findings make sense? And this is really the more difficult, or the forensics part of data profiling, and it requires the input from subject matter experts for the data being profiled. It's a manual inspection of the data for rational values. So a field in the EHR labeled temperature may contain data in the correct format, but the range of the values may exceed what's logical from a clinical perspective. So if you have a temperature over 500, that's really not a valid temperature for a human. Qualitative analysis can also identify data fields that capture similar information in different ways. And I can't stress enough how critical it is to involve those data needs in this process. You need folks that understand the workflow for how data is created. For instance, I was working on an immunization project, and I came across a lot number field for an immunization that contained a high percentage of punctuation marks. And so I sat down with the SME and looked at the workflow of the clinicians, and I learned that, one, the lot number was a mandatory field, and I also learned that the end user screen wasn't able to capture any of those combo vaccines as one vaccine. So if a clinician was administering a hepatitis A and hepatitis B combo vaccine as one shot, it actually needed to be documented and recorded twice in the system. So from a workflow perspective, they recorded the lot number with the one of the vaccines, but not with the other. And they couldn't bypass because it was mandatory, they couldn't bypass that lot number field to the second vaccine, so they entered a punctuation mark to get by it. So the more, combo vaccines we gave, the more punctuation marks that we had in that field. The other thing you can learn from your data SNE is really the relevance of the data. So along that project, looking at immunization, and we're getting ready to migrate legacy data into a new HR. And, each immunization, when it's giving, produces transactional data, like, what was the dose, what was the name, what was the route, those kind of things. But from a clinical standpoint, the transactional data was really irrelevant to the clinicians. All they wanted to know was what was the immunization and when was it given. So as long as we had a plan to be able to retrieve any of that really necessary information, like the lot number, in case there was a product recall, then we really didn't need to migrate all the transactional information to meet the clinician's needs. So the qualitative assessment can also identify, a hijacked field. And what I mean by a hijacked field is it's a field where the use of the field is not what its intended use is. So from a quantitative assessment, you may find that data values in a field don't match at all what you expected. And you think, oh, this is a hijacked field. You review the data creation process as a workflow. You discover that the screen where the data is entered has different questions associated with the field. So an example is on one screen, the end user is asked to enter, say, a smoking history as a pack per year number. And on a different end user screen, the end user is asked to enter the year the patient quit smoking. They're going to yield different data, and it may appear that the field is hijacked when, in fact, the end user is using it as designed. We just had inconsistent screen design. So these are really example classifications of findings from a quantitative and a qualitative review. We talked about, null values, field length, format compliance, from a quantitative perspective. And a qualitative perspective, are they compliant with your reference table values? Were there hijacked fields? And then we can sort them into data reliability from a high, medium, and low. So let's take those data reliability categories into a little bit more detail. Categorizing individual data elements into data reliability categories really supports the decision-making about where to focus your efforts and what kind of effort will be required to remediate the data. So high reliability data is characterized by a high degree of consistency between the expected data findings and your actual data findings. And additionally, there's strong processes in place to maintain the consistency of the data. That could be something like a field that doesn't have a free text ability, you can only choose from a drop-down, or a field that is limited to a numeric value, being able to enter only numeric values because it's a numeric field. And additionally, qualitative data assessments reveal a high probability of accuracy for the data. So there's really a low probability of clinically improbable data. Medium reliability data, it's characterized by a variable degree of consistency between the expected data findings and the actual. So that qualitative data finding might include, a discrete data field capturing data from multiple different reference tables, or multiple data fields that capture clinically similar data in different ways. Data has a medium reliability if there needs to be some type of transformation or mapping to some type of standard values from multiple data fields to one data field. Take, for instance, that gender example that we used earlier. That would fall into a medium reliability category, perhaps. The low reliability is really a high degree of inconsistency between the expected findings and the actual findings. And processes won't be in place to improve the consistency of the data. This could be a free text-only field. And qualitative data assessments reveal a high probability of inaccurate data. So that could be that field that has all punctuation marks within the field. So where do you apply data profiling? It's really useful anywhere you need to establish a realistic picture of the current state of your data and help guide your efforts to improve its reusability. So it could be to support your data governance program, repurposing data into analytics, if you're trying to interface systems and you need to resolve data conflicts, or even if you're getting ready to migrate from legacy to new systems. So I'm going to turn it over to Lori from Lehigh Valley, who will walk you through their real-life experience with data profiling.
Thank you, Joy, very much. I really appreciate the opportunity to speak at this time. I think that to date, Randy and Joy have really built up a good reason why you want to do data profiling, but I feel that I can really add to this by taking you a little bit deeper into not only the findings that we had, but how it benefited our organization as a whole. We are Lehigh Valley Health Network. We are in Allentown, Pennsylvania. For those maybe not familiar with Allentown, it's about 2 hours south of New York City and about an hour north of Philadelphia. We're one of the largest academic community hospitals in Pennsylvania, a level 1 trauma center. We have 3 hospital campuses, an employee physician community of about 700 physicians, and as you can see, we have a pretty good presence in the organization, or in the region. One of the challenges that we had over time is not only are we a large organization, but we're fairly sophisticated in the use of technology. And over the years, we had purchased specific software applications in order to accommodate the particular needs, the medical needs of our physicians. So, for example, we had a main HIS system, but we had a separate emergency department system, a separate labor and delivery system, a separate cardiology system. And after a period of time, our physicians who are very facile with using computers said, this is too much. There is no one central point of area for us to be able to get one clinical view of the patient. So 2 years ago, Lehigh Valley Health Network, as well as many other institutions in the United States, made the decision to move to Epic. So we would have one application that would handle all of our users' needs. Along with that meant that we would be collapsing approximately 25 different applications and sunsetting them in use of the new Epic application. If you move to the next slide. So our problem here is that when we said we wanted to actually move these legacy applications, Epic said that's really not something that they would support. They felt that it was a very much of a risk. Many of their organizations chose just to pretty much go live without having any data migrated. And we had a lot of talks with other clients as well and said, what did you do? And every single one of them said that they did not do the migration, and it was all in regards to the to the issue with the data migration quality. They didn't want to migrate data that they felt was not good. So we were really struggling there for a while because this was something that we felt we would be able to deal with. In addition, we did have some concerns with our ambulatory system that there may be situations with hijacked fields, and I know that Joy had explained that earlier. We were concerned that perhaps we were reusing fields that maybe were not necessary for other purposes, and we needed to actually get to the bottom to see whether it really was an issue or not. So the other challenge we had, as far as, remember I said we were going to take 25 different systems and collapse them into Epic. If we were actually going to do this and move forward with data migration, one of the challenges was going to be, where would we take the allergy from? Would we take it from the inpatient system or the ambulatory system? Of course, allergies are in all the different systems, and there was no standardization as far as one lookup list for all of the allergies. So once again, that was another reason for us to engage. So we actually contacted Encore and said, we're not really sure what we want to do. We want to do some kind of data profiling, but we would like you to kind of help us on this road. Can you go to the next slide, please? So our objective here was basically to focus on our inpatient, ambulatory, and emergency department systems and basically do an analysis to really understand what we were getting into, and also to kind of firm up our position with Epic to say, yes, we do feel comfortable in migrating this information. On the next slide, I'm going to move more into some examples, and this is where we really get into the meat of the discussion, but I think it really shows and it really exhibits the value of this information. So, you know, we're silly. We go to Encore and we say, hey, can you do this for us? And we want to look at things like immunizations, you know, tobacco use. And they come back and say, do you see that, for example, tobacco use, there are 20 different distinct data elements that you need to look for. And this is only in our ambulatory system, so we're only looking at one system here. So now the challenge is, okay, we have all of these different fields. What are we actually going to focus on, not only for the content, but also the cleanliness of the data, and what is really pertinent to move over to another system? The next slide is very busy, but it shows more of the detail of the initial findings that you had in regards to this. It's more of a snapshot of the larger spreadsheet, but it shows each of the particular fields and what we thought we would be able to find and what it was really being used for. So what I'd like to do for this example is focus in on, I think it's the fourth line down, smoking year start. So theoretically, you would assume that that's going to be a numeric field, and that is going to contain the year that the patient started smoking. On the next slide, we're going to see that this is what we did expect. So we saw smoke year start, and it would be a numeric value, and what we thought it would be, and what we expected it to be. Yet when we move to the next slide, we see that that's really not what we found. If we look again at the fourth line down, you'll see smoke year start. Well, guess what? Some of the data was numeric. Some of it was a text string. And we really were not expecting, we did not see the year 1965, for example, in all of the cases. So then that leads to a little bit of a credibility as to what are we actually going to be able to do with this. Now, one could go back and say, when we had configured the system initially, we should have put some kind of editing on the fields to allow that. But these, once again, these are systems that had been in place for a long time, and that editing obviously was not working. So the next slide, I think, really breaks it and gives solid examples of the definitions that Joy had originally said when she gave her explanation a few minutes ago. When we looked at our data, we looked at the high reliability. So you can see here we felt very good about things like height and weight. You can see in the qualitative it said less than 0.01% of the values are clinically improbable. So it's very important for us, and once again, as Joy said, not only that the data looked right, but that it was clinically relevant as well. So those were data that we knew we would be able to move over and not have any issues with. When we go to the next slide, we see medium variability or reliability, and that's where it gets a little bit trickier. And right back to our smoking example, which I had alluded to before, you'll see there's various different fields that are being used for basically the same thing. The information, for example, smoking status today is an interface field. So there are clinically similar data elements that had a lot of similar information, but yet it was very hard to be able to grab consistency or standardization in the data entry. Out of the analysis, it appears that smoking status was the only one that seemed to be the most consistent. When we move to the next slide, we see low reliability, and you'll see that our favorite field is there in the third entry, smoke year start. So once again, we're back to, we thought it would be numeric, but it was numeric in a text string. So really, after the analysis performed, we only felt 60 to 75% comfortable that the information would be accurate and that it would be followed up with a reference table that would make sense to us. So it really gave us a lot of background and a lot of really tangible things to take action on, not just the profiling, but these results as well. On our next slide, we're going to go into the second example, which now if you go back to our story at hand, the first one was saying, go to our ambulatory system and find what fields there might be questions with. Now we're going to the second challenge that we had, where we have multiple fields across systems that are actually the same. So for example, we said to Encore, can you check allergies and tell us how they look in general, which systems are the best ones to actually move data over. As I mentioned earlier, things like problem lists and allergies were key, and we really felt that we could not go live with Epic without moving that data across as a starting point for our physicians. We did not want to rekey, nor did we want them to be stuck and re-entering that information. So we did a comparison. Unfortunately, you'll see the same situation as we had before. In the ambulatory system, there were 15 different data elements, not as many in the inpatient EMR. And we're going to follow the same profile that we did before. So we move to the next slide. You'll see the summary of the categories. What was the high reliability, medium, low, and then what they said they just agreed, do not migrate at all because of the complexity or the inaccuracies of the field. The next slide is somewhat complex, but as I walk through it, I think it will make a lot more sense to you. What I'm going to initially do is move down to the system where it says inpatient. It's the third and fourth lines. If you look there, you're going to see, for example, the name of the allergen, the description of the field name. There's a very high reliability, and one of the things that we had actually done, I think it was a few years ago, about 5 years ago, in the inpatient system, is we had linked a good table, reference table behind that field, and we did not allow users to override it. So we felt very comfortable that there were no non-coded allergens in that field. So we were very happy to be able to say that. Ambulatory side, not so much. Did have also a lookup table, but allowed the overriding so that you could enter free text. So we were able to go back to our users. We had a committee that was set up to determine what fields would be converted. And we were actually able to say on the ambulatory side, we had a 25 to 30% questionable rate as far as how things were going to move forward. As I continue on telling this story, it really helped us shape the information that we needed in order to really configure the conversions. For example, right now we are going to be running the inpatient allergies directly into the Epic system, a direct feed, and there will be no interaction from a human at all because we know that that data is coded and it will migrate into Epic cleanly and there will be no errors. On the ambulatory side, we had to take a different approach. Knowing that there was a 25% non-compliance rate, we decided that we would implement a CCD type of data migration. So basically that means that we will export a CCD from the ambulatory system, and the physician will be presented with it, and he will have to manually reconcile those allergies. So for the most part, he will just be accepting what he sees, and it will be easy. But for that 25 to 30%, we can guarantee that he will be reconciling it, and only the right information will come into the Epic system. So overall, telling that story, I go to the next screen, which kind of says our lessons learned and our overall themes. We had just really an eye-opening experience with this engagement, and it really helped us understand the benefits of data profiling. And not only, everybody says, yes, you should profile your data, yes, you should have clean data, but we were able to actually see tangible results and take it forward in order to actually make the points and give a business case for where we needed to be. Some of the findings that we had no hijacked fields that we had identified, so that was really key for us and really important for us to be able to move forward. Some of the clinically similar data fields that were captured on multiple screens were a little bit of a challenge because we were not able to see whether they were really being used the same across the board. So that goes back to the whole concept that Joy had mentioned. If you don't have the same reference files behind the screens, behind the themes, you're going to have a challenge. We also had some issues as far as if you had a field that was deemed mandatory and you did not allow the users to bypass it, sometimes you're just going to get junk in that field, so it's really defeating the purpose. So you're going to find maybe more garbage in those fields that you weren't anticipating. Strong user processes, if they're in place, you're going to guarantee a lot more clean data on the back end. For example, we have barcode medication administration in our inpatient settings, which really put us in a position to be able to understand that you have very little human interaction there. You're swiping the patient with a barcode reader. So that's going to be directly into the system versus somebody actually having to put that information in. So if you have those solid processes and rules up front, the cleaner your data is going to be on the back end. And one of the biggest things that we learned here was the understanding of the workflows and the barriers to the workflows in order to effectively move forward. One of the things that I know I had misjudged when we started this was the need for the SMEs who really understood the system. We had the technical resources lined up to extract the data for ENCORE, with the necessary ENCORE experts available to actually analyze from a forensics point of view the data, but we really needed to have those SMEs. They're the ones who understand how the data is entered into the systems and how it's really used. So we ended up really having them become part of the team as we went through this journey to understand where we were moving forward. Nico, to the next slide then. Overall project benefits, one of the biggest things we found out was, and I use the word ammunition, and I know that that's a negative connotation, but with Epic, we were really changing their model of how they moved forward. We actually had to fly out to Wisconsin several times to actually make our case. And they had their position, and it was understandable that from their point of view, they needed to make sure that the data was as clean as possible. Based on the information we received from ENCORE, we were really able to state our case and say, look, I can tell you 100% that the inpatient allergies are clean and the ambulatory allergies have 20% to 30% issues with them. Having that kind of information really put us in an excellent position to be able to move forward. The results also provided us with the guidelines that we needed to support our data migration. For example, the story I told you about on the ambulatory import, we chose a CCD import to do the manual reconciliation versus a straight data load. And we were also able to just go back and talk to Epic and organize ourselves as far as putting us in a position. We felt much better about the data that we had looked at. So the story that I'm telling you that actually started 2 years ago, we will be going live with Epic in February of next year. We are currently going to be starting our production loads for our data migration in 2 weeks. We are actually migrating 25 different sets of data, categories of data, and that's about the highest that they've ever experienced. So we're really one of their few candidates to be able to go that far. one of the reasons we also felt very comfortable is that, as I mentioned earlier, we were in a very automated state. We had 100% physician order entry compliance. We had medication barcode entry. We had a lot of sophistication set up, and to be honest, we weren't going to lose all of that valuable data. So I think one of the things that we talk about all the time is that data is really a valuable asset. But if you don't take care of that asset and you don't really make sure you're using it properly, one of the greatest things that I think Joy says is that even if the data is entered from a mechanical point of view correctly, if it's not clinically relevant, that's some of the things that you need to really watch for. And if we're really going to move forward with any kind of performance analytics in the future, data is really the foundation. If you don't think you have clean data, then you're never going to be able to move to that next step. We're very excited with the functionality and the data analytics that Epic will be able to provide us. And I feel that we are in a much more confident state to be able to utilize those analytics, knowing the state of the data that we have right now. I think that's it for me.
Okay, thank you. Now we'd like to open it up to the audience for questions. As a reminder, use the questions box on the GoToWebinar console to submit your questions. The first one is, how did you reconcile the entries on the same patient who was in the ambulatory EHR system as well as the inpatient EHR system?
The allergies?
It says, how did you reconcile the entries on the same patient who was in both systems?
So basically, we took it not necessarily from a patient perspective, but we took it from a category perspective. So in the case of allergies, for example, we will have loaded in all of the inpatient allergies, and then we will also present the ambulatory allergies to the physician when that patient is there, and then we will be able to, he can see whether it's already been entered on the other system or not. I would say allergies with medications, we only took ambulatory medications. Problem lists, we were somewhat lucky in that we only took ambulatory problem lists. So allergies was one of the main areas. I would also say vital signs was another area. So we were able to reconcile that when we were actually brought the two systems together, or the patients together from the various systems.
Okay. Can you tell us what the sample size was for your data profiling?
Sure, I can address that. So we looked at, a maximum of a year's worth of data, and we know that some fields are populated more frequently than other fields. So we wanted to have a minimum of 5,000 records just to give us an idea. And we went out at least to a year to be able to get that full 5,000 record minimum count. And sometimes even at a year out, we didn't get a full 5,000 records. It just really depends on the frequency of documentation in a specific field. And some fields are used much more frequently than others. That was just an example for this case. Anytime you're doing data profiling, it really depends on, your sample size really depends on what you're trying to do with the data. If you're trying to migrate data from a year back, then you want to go, a year back. If you're trying to move data into a data warehouse, you want to really profile all of the data that you're getting ready to migrate so that you're not cluttering your warehouse with garbage in, garbage out.
Okay, thanks, Joy. What tool did you use to profile the data?
I can take that again, too. So for this project at Lehigh Valley, we actually used Excel and some pivot tables because we were only using, a minimum record set of 5,000 records, which isn't very big. But I have used other tools that you download from, it's free web stuff you can download from the web. There are commercial products out there that you can use when you want to really put this into your routine, metadata management, life cycle. But you can use any of those type of tools to help you.
Okay, thanks. Can you tell us, how did the migrated data appear for the first time when the physician looks at it?
So we've had, it depends on what the data is. As I mentioned, we're taking about 25 different categories of data. So when the physician brings up a patient, the demographic information will be there. For example, it was very specific. We made a concerted effort or a concerted decision to say we're going to bring over demographic information and some of the patient flags like VIP or do not announce, but we weren't going to bring over insurance information. So they'll see the demographics. They'll also see the problem lists. They will see the allergies, but they will also be alerted that there might be allergies that they need to reconcile. So there's a button within Epic that kind of flashes yellow and says, please look here, click here to reconcile the allergies. For the medications, it'll be the same thing. They did not come in automatically. And our physicians actually felt more comfortable with this. We've been demoing it, and it is a strategy that we took in a previous model, moving from EMR to EMR. As far as other information, such as notes and transcribed documents, they will be presented in the chart just as they had seen. Lab results will have come over as well. What we did was we assigned time frames to each of the categories. So for example, lab results, we may have 20 years of lab results. We only brought over the last 3 years. We will only bring over the last 3 years of certain documents within a chart. So when the physician comes in on the first day, we would like him to have as much of a composite information that he can, knowing that he will still have to perhaps look into the source systems, but kind of weaning him off of it sooner than later.
Okay, great. Good answer. You actually answered the follow-up question before I got to ask it, so that was perfect.
Oh, okay.
Did your assumptions through the profiling process prove to be valid in your migration tests? Yes, I think that in some ways it was good, and in other ways it was surprising. We loved the results that we got. For example, allergies to me is just the example I go back to all the time. We felt that the inpatient stuff was probably in a good state, not so much on the ambulatory side, and it was just really great to be able to go back and then take that information. So with a 25 to 30% error rate or inconsistency rate on the ambulatory, we could have decided just to not take any of that information. The concern there is that the populace of your allergies are going to be in the ambulatory setting. You're only going to have allergies collected if you're actually on an inpatient. So we had to take that and meter it against the volume of the information as well as what was good, and to be able to say, okay, do we take and just drop that 25% that wasn't good? Do we go back and maybe try and fix it? That was another opportunity that we had with the information that Encore gave to us. We could have gone back and changed a lot of those allergies. That's obviously a resource issue. But we were very happy with what we saw. And for example, the smoking information, that was upsetting because there was just a lot of stuff out there. But it really helped us to kind of hone down and say, if we're going to take smoking data over, this is the only area that would really be worthwhile to take over. So it was very invaluable from that perspective. Okay, thank you. And of course, this question always comes up. What was your biggest challenge through this process? Through the data profiling process? Yes. I think the biggest challenge was just trying to get our arms around what we wanted to do and kind of align the resources to effectively give Encore what they needed, and then to be able to really sit down and understand what we had after the engagement. Joy, I don't know if you want to add something from your side.
No, I think that's it. It's prioritizing your data and at times it was difficult to actually pull the data out of the source system. We were wanting to do some data pulls from the emergency department, and we needed to get the vendor involved to be able to help us pull the data from the actual source. So those are some of the biggest challenges that we ran into. That, and you're implementing Epic, so there was a resource constraint in trying to get with the folks because they're busy.
Right.
Okay, I have one more question for Lori. How did your governance process work to help you achieve this change?
So we had different levels of governance throughout the EPIC project itself. We had an overall steering committee, and then we actually spawned off a subcommittee that was formed just for data conversion. So came together with them, and we really tried to rally them and organize them into a position of data categories, because if you go to any physician and you say, what data should we migrate, their first answer is going to be everything. So what we tried to do was say, okay, let's talk about allergies, let's talk about problems, let's organize ourselves into categories that we were going to address. So first we identified those, and of course this was after the, it was coming to the end of the Encore engagement, so we really were in a better position to be able to guide them, as to what data would be relevant and what wouldn't. So we had actually two committees. One was the subcommittee for data conversion, and then there was a clinical decision support committee that was actually chaired and a lot of members of the physician community that contributed from a clinical perspective. So there were various levels. One was to agree with the categories of data that we would bring over, and we got that signed off. And then the next round was actually the components of the data to actually go and say what we were going to take and what we weren't going to take as far as the time frames. So we would take 3 years of labs. There were certain labs that they felt very, like genetic testing, that they wanted to go back 10 years, so there were subsets of that. So we actually went through each of the categories, drilled through them, and actually set the actual precedent of the specifics of moving forward. From there, we thought, okay, we're set, EPIC's on board, we're going to move forward, and then we really got into the information, and I think Joy mentioned it well, that immunizations were quite a challenge for us. They really were. Immunization, yes. Immunization at Walmart, so you obviously can't take a lot of that information over. So then we had a subgroup of our champions, physician champions, and some of our clinical champions that we would run by some of this information and say, okay, we're going to try and take as much of the immunization data as we can, but when you look at these types of entries, can we just say we're not going to take that? So we kind of took each category based on the requirements, and we kind of whittled it down from there. And then after that, we got final sign-off by the conversion committee and then up to the steering committee for EPIC. And at that time, we were already running some of the initial loads just to make sure that we could follow through with what we were doing.
Okay, great. Another question just came in for you, Lori. Did you consider CCDAs and the consumption of CCDAs to migrate data for meds, allergies, and problems?
Yes, we did. We were very lucky to find a company who was able to produce that. So we've actually taken that strategy for exactly that same purpose. So from the ambulatory side, for the inpatient side, we will load allergies right in. On the ambulatory side, we are loading in allergies, meds, and problems through a CCD, and the physician will be presented with a reconciliation list, and then he'll do that manual, actually manual, but online reconciliation from that CCD consumption.
Okay. That was our last question, so it concludes our webinar. Thank you, Randy, Joy, and Lori, for a really informative and interesting presentation, and thank you to everyone who attended today. Attendees can expect to receive a follow-up email from us with a link to the recorded version of the presentation as well as a PDF version of the PowerPoint presentation. I look forward to seeing you at another HIS Talk webinar soon. Have a great day.